Good afternoon. We'll give folks just a few minutes to get into the Zoom room, then we'll get started. So hello, my name is Michelle Wagner, and I'm with NAMI New Hampshire working on the first episode Psychosis Early Serious Mental Illness Initiative. Thank you for joining us today for our webinar titled Tardive Dyskinesia, Recognition and Treatment. Today's presentation is being recorded, and you'll be able to find it on the education page of the onwardnh.org website. Though we aren't offering formal CEUs, we will be providing a certificate of attendance. You'll receive that automatically when you complete the evaluation after today's presentation. This is a Zoom webinar, which means your camera and microphone are off. The chat and Q&A features are working, so please enter any questions you have there. Emily Huff is providing technical assistance for us today. So together we'll work to get those questions answered. And joining us today is Dr. Jeffrey Reed. And rather than read his bio, we'll have Dr. Reed go ahead and introduce himself. Jeff?
Thank you very much, Michelle. So yeah, I'm Jeffrey Reed. I'm one of the faculty psychiatrists at Dartmouth-Hitchcock Medical Center and Geisel School of Medicine. I am teaching faculty for the resident program here at DH, and teach second, third, and fourth year students both at the medical school and on the units here at the main hospital. Much of my background has been in psychosis. Did research as an undergrad, moved over to the National Institutes of Mental Health after I graduated college to do a research fellowship in schizophrenia, and then subsequently moved to MGH after that prior to going to medical school. During medical school, during my residency, I worked closely with Dr. Douglas Nordzi, who was one of our more resident experts in psychosis, who's now at Stanford. And I've pretty much kind of followed in his footsteps here at DH. So very happy with the job I'm doing. I do have some of my time I do spend at West Central Behavioral Health, which is a community mental health center in Lebanon, New Hampshire. Formerly worked the served community treatment team, and now work the community support team, where I largely work outpatient with folks with severe mental illness as well. Okay.
Great, thank you, Dr. Reed. So now you will go ahead and share your screen. We'll have Emily take the opening screen down, and we'll listen to this important presentation.
All right, let me get things squared away like we did before. Portion of screen, yeah, portion of screen, and then, Good. All right. Can Michelle, can you see everything?
We can.
Okay? All right. Good.
Perfect.
Good. So today we're going to be speaking about a condition called tardive dyskinesia. Tardive dyskinesia, I'll describe more in detail what that is sort of one of many neurological conditions that can arise from the use of neuroleptic medications, right? We have several others there, and they fall within a class of things called extrapyramidal side effects. So it's a series of movement disorders that could include not only this condition, but also tardive dystonia, Parkinsonism, akathisia, a lot of different conditions that are more neurologically based, but also caused by the medications that we use. In fact, tardive dyskinesia is largely a medication-induced condition, and not as often seen spontaneously or organically in neurological medicine. All right. Good. So I'm going to play a little video here. This is probably the fanciest part of what I got to show you. about what dyskinesia looks like. Okay, and this is from the JAMA network. This is sometimes what we'll often see with folks who have a tardive dyskinesia. Let me bring this up and get it playing. Here we go. So tardive syndromes are neurologically based conditions that develop over long periods of time and a product of chronic treatment with what we call dopamine receptor blockers. Okay, so if you think about medications that we use to treat schizophrenia or even bipolar disorder, those medications work primarily through blocking dopamine in the brain. Okay, and we try to target as best we can just blocking dopaminergic brain activity. However, it does include other areas. What you're seeing here actually in this slide, in this video, is what we know to be orofacial dyskinesia. Now, dyskinesias are broken, really, well, movement disorders are broken down in two different classes. Okay, there's hypokinetic and hyperkinetic, whereas hypokinetic movement disorders present with notable slowing of body movements, such as bradykinesia or Parkinsonism. The hyperkinetic movement disorders include dyskinesia, choreiform movements, and actually kind of show up as almost purposeful movements that include multiple muscle groups. So as you saw in the video, you could see, let me see if I can play it again. I might not be able to. You can see sort of this chewing action, this rhythmic movement of the lips. So you can get a thing called lip smacking. People will sometimes accidentally bite their tongue because of this automatic movement. Now, these are not movements that a person can control. All right. This can sometimes be affect other muscles other than the facial muscles. So things like what we call the paraspinal muscles. It can help affect the muscles of the pelvis and also the extremities. So you can see similar kind of muscle activity in those other areas. And those who, and sometimes for those who may be on these dopamine blocking medications over long periods of time, they may start to show, they may not show evidence of a dyskinesia where you can, someone outside themselves can really see it. They may notice themselves sort of a burning sensation or an irritation in their mouth. Okay, so I mean, when we're seeing people clinically, that'll be something we may ask about. Hey, do you sometimes bite your tongue? Do you find yourself noticing sort of like an uncomfortable feeling in your lips or around your tongue, or even swallowing? And that can be early evidence of a dyskinesia. Okay, so tardive dyskinesia is actually also highly correlated with a poor quality of life we've seen, which further underscores the importance of developing effective treatments for managing this condition. Sadly, only about 13% of patients who develop tardive dyskinesia from their antipsychotic medications experience full resolution of the condition, and full cessation of someone, even after you discontinue a medication that can cause something like this, very rarely. I mean, that's actually about 13% of those folks. Ultimately, even to get a resolution of those symptoms in that 13%, it takes over 2 years. It can be close to 2.5 years for those symptoms to resolve. So even when you stop the medication, it can prolong for a long time. Some people, as you might imagine, it lasts forever. Okay, it does not go away. So targeting treatments that might be able to address this are really, really very important and improve people's quality of life quite a bit. Okay, so I want to go through a little bit of a background of why these things may develop. So in order to understand tardive syndromes, we really need to start to understand the basic underlying sort of neurophysiology or neuropharmacology, as well as brain circuits that are related to schizophrenia, as well as the treatment of schizophrenia. So what we know to be a large part associated with the condition is through dopamine. Okay, so dopamine is a major excitatory neurotransmitter in the brain, and neurotransmitters are chemicals in the brain that communicate between cells called neurons. And they also can communicate between brain areas. So you get these long circuits that can go from one area of the brain to the other. And it's these chemicals that allow for that communication. When we think of illnesses such as schizophrenia, we first need to understand that dopamine plays a significant, although not exclusive, role in the condition. And the condition is also associated with sort of heightened dopamine activity in some regions of the brain, which are associated with things like hallucinations or delusions. And in other parts of the brain, it can actually be sort of seen in as sort of underactive. So certain areas of the brain, there's less dopamine activity. In other areas of the brain, there's heightened dopamine activity, which can be very characteristic of the condition. That's why you start to see all those different symptoms, which more of like a syndrome that we know as schizophrenia. Now, there are four main pathways of the brain that we know to be related to dopamine. Okay, I'm going to start to go through some of those here. One of those particular pathways is more associated with the movement disorder of tardive dyskinesia. Okay, so the first being the mesolimbic pathway. So the mesolimbic pathway is that's associated with what we know in terms of positive symptoms of schizophrenia, things like auditory and visual hallucinations and delusions. The next pathway is known as the mesocortical pathway, which is associated with learning and memory. And then there's the nigrostriatal pathway, which is associated with the controlled motor movements. It's this nigrostriatal pathway that's actually associated with what we know as tardive dyskinesia. And it's having to do with altering the tone of dopamine in that pathway that leads to this condition. Okay. The other pathway that we also know is affected not only in people who take these medications, but is part of the three other pathways that are largely dopaminergic, is the tuberoinfundibular pathway. And this largely has to do with your brain, so your brain and ability to regulate hormones throughout the body. So hormones being similar to kind of like neurotransmitters, they communicate chemically with other parts of the body far away from where the source of where the communication starts. Okay. When we think about tardive dyskinesia, it's the nigrostriatal pathway that we really focus on. And it's that pathway that's adversely affected by the same medications that we use to treat schizophrenia. It can actually affect that particular pathway and causing the movement disorders that we see because of the medications. So tardive movement disorders originate in the central nervous system and specifically in the basal ganglia within the nigrostriatal pathway. And that includes the striatum, which is the caudate and putamen, the globus pallidus interna, and the substantia nigra. All these regions are really heavily sort of communicated with them in terms of with dopamine and act dopamine 2 receptors and allow for that transmission. Okay, conditions such as tardive dyskinesia develop from sort of this extensive blocking of dopamine 2 receptors in that region. Now, we still don't know exactly the mechanism that leads to this condition. It's long been proposed that dopamine 2 receptor blockade in this circuit results in sort of this reflexive upregulation of dopamine 2 receptors to normalize the dopaminergic state. So basically, if you've got a medication that they're taking to treat their illness, right, and is effective in treating their illness, well, it doesn't just affect that one pathway that treats their illness, it affects all these other pathways. So if you block dopamine in the nigrostriatal pathway, what happens is it's presumed that there's an increase in the number of receptors on cells that receive dopamine transmission. And as a result, what happens is if you were to discontinue the medication, you get a huge flux of dopamine that activates all those new receptors, which can actually worsen tardive dyskinesia, at which point you want to actually treat it. So we can go over how we best address that. However, it's because of this upregulation of these dopamine 2 receptors that we believe we develop this movement disorder from those medications. Okay. All right. So in individuals living with severe mental illnesses such as schizophrenia or bipolar disorder, antipsychotics may be used to treat both acute and chronic psychotic conditions. They can treat bipolar mania, they can treat bipolar depression, and also serve as an augmenting drugs for the treatment of such conditions like major depressive disorder, obsessive compulsive disorder, and even PTSD. Now, whereas tardive dyskinesia was largely seen in individuals with schizophrenia, it can be found in a broader population due to just the prescribing practice that we see for these other conditions. So if you can have a condition like schizoaffective disorder, schizophrenia, be treated with these medications, you develop tardive dyskinesia, and it's largely because of the medications. Well, if you have major depressive disorder or bipolar disorder and you have to start these medications, you could develop that as well. Okay, so it's not just, we see it a lot in patients with schizophrenia and these primary psychotic disorders. However, it's because of the medication, not because of the illness itself. Okay. What we find though is there's certain medication classes that are more likely to cause tardive dyskinesia, that movement, this really severe movement disorder that does develop over time due to long-term use of these meds. So what we find is that with first-generation antipsychotics such as haloperidol, fluphenazine, or chlorpromazine, these medications carry a high risk of causing tardive dyskinesia with their chronic use and are associated with a high affinity for dopamine receptor blocking in the brain. So what's interesting about those first generation medications, the older medications, is they more heavily blocked the D2 receptors, not only in the areas that treated schizophrenia, but also in the areas that are responsible for movement, for hormone balance, and even for cognition. Okay, so these medications not only can help the condition, but worsen other conditions like movement disorders or cause these movement disorders. And the reason that's the case is because these medications were very strongly blocking D2. Now, the newer medications like the second generation drugs, things like quetiapine, also known as Seroquel, clozapine, which is the most effective medication we have for treating schizophrenia, and olanzapine or Zyprexa, they're less dopamine blocking. So they don't have as much of a blocking capacity at D2 receptors. Therefore, they're less likely to cause things like tardive dyskinesia or these other neurological conditions that are due to these medications. What you see here is dopamine receptor blocking. We're going to see this a lot in the presentation. Dopamine receptor blocking means these medications make it unable for the cells in the brain to communicate with dopamine between those two cells. Okay, and that's what a lot of these medications do. The third generation agents, which are things like aripiprazole, I think brexpiprazole, and those kind of meds, not only are they dopamine blocking, but they're also dopamine activating. So what they do is because of that dopamine activating action, it's less likely to cause these different conditions. However, there's still a little bit dopamine blocking. Therefore, they can still cause tardive dyskinesia in some people, but it's less likely as far, and these medications are far more tolerable over time, especially the longer you take them. And these medications, because they both block and activate dopamine 2 receptors, that's why they're called partial agonists. Okay, that's where that comes from. Okay, now the early studies investigating the impact of these dopamine blocking drugs found that tardive dyskinesia actually occurred on average between 20 and 30% of all patients who take them. Okay, a recent meta-analysis of about 41 studies revealed an average risk overall of 25% in all treatment groups, regardless, I believe, of first generation, second generation, or third generation drugs. Okay, though they did find, however, that of those who are taking first generation antipsychotics like haloperidol or fluphenazine, or even chlorpromazine, roughly 30% of those folks developed tardive dyskinesia. Now, compared to those who are taking things like Zyprexa or Seroquel or Abilify, about 20% of people developed tardive dyskinesia. So that's not a big difference. I mean, this risk is still very high in those second generation drugs where they're supposed to be less likely to cause it. They're pretty much still the same. Okay. Though in many people, and especially clinically, I've seen it occur less in less severity and be much more manageable once it does happen. So let's see here. Okay, all right. So of the ongoing maintenance treatment for first generation agents, the risk of TD was about 32% over time. So when we think about the longer someone stays on medication, the more likely they're to develop the condition. If you remain on a first generation medication like Haldol or fluphenazine, the risk of TD was about 32% about 5 years of treatment. It goes up to 57% at 15 years of treatment. And then after 25 years of being on a medication like that, 68% of people who take that medication develop tardive dyskinesia. Okay. All right. So not just one of the things that we also want to remember too is, yeah, these medications do cause tardive dyskinesia and put people at higher risk for developing it. There are actually certain conditions that you have control of or you don't have control of that may contribute to your risk of developing it once you start these medications. Okay, so we call these non-modifiable risk factors. So a couple of things that increase your risk for tardive dyskinesia is older adulthood, female sex, white and African American descent, intellectual disability is another another state in which you put you at a higher risk of developing this condition, and also the co-occurrence if you have schizophrenia, having something like a major depressive disorder or having a history of bipolar mania. Those, if you have a co-occurring mood disorder like those, it puts you at higher risk of developing a tardive dyskinesia, especially when you start these medications. Right. Now, the risk factors that you can control if you're on these medications are, one, as a doctor, it can, the type of medication you use and the doses of medication that you use really strongly predicts if someone's going to develop tardive dyskinesia. So we really encourage, especially when I'm training the med students and the residents, start the lowest dose necessary to start and only increase it to a dose that they really need to treat their condition, and do not go any higher. And if at some opportunity you can reduce the dose back down, you're welcome to do that. Okay, and I would very much encourage it. And if people were to develop more of these sort of signs of tardive dyskinesia, or even other movement disorders like a dystonic reaction, it gives you have reason to either decrease the dose, find a different medication. So part of this is going to be sort of physician dependent, okay, in terms of what we can do to control and prevent this condition. The other thing is, if a patient has a prior dystonic reaction, so what that really is, prior history of developing real significant muscle stiffness, it's painful muscle stiffness, muscle spasms, things of that nature, or have a neurological condition that can lead to a dystonic reaction, that can also contribute to someone developing tardive dyskinesia, especially when started on these kind of medications. And then the use of tobacco, alcohol, and other substances also increases one's risk of tardive dyskinesia. So we always, as we would in any mental health or medical condition, work really hard with people to help with smoking cessation, helping with reducing alcohol use, and even finding treatments that are meant to address those or prevent those from worsening. Okay, because just by virtue of the fact that you're engaging in that substance use, it does increase your risk of developing a tardive dyskinesia. Okay, so prevention and management. So first and foremost, we want to focus on the early signs of tardive dyskinesia, and doing so through evidence-based screening. The longstanding standard of practice is the use of what we call the abnormal involuntary movement scale. It's something we do often in the hospital, something I do in my outpatient in my outpatient practice. Is you have a standard screen, you sit with someone for about 5 or 10 minutes, you can go through it, and it gives you a measure, it gives you a number, and you can track that number over time when they're on these medications. I'll typically do a baseline screen when someone comes in, and then every 6 to 12 months, based on what's currently the APA recommendations for monitoring when someone's on these medications, and also depending on their risk factors, I will continue to monitor based on this scale. Right, so that's one way. So if you start to see their AIM score gradually change over time, increase in particular, then you want to start to look at, is this because of the medication? Are there certain things they're doing? Are they smoking more? Are they drinking more? Those kind of things you want to pay very close attention to, because then you can start to address it before, one, it gets so bad that it really starts to affect their life, or they start to notice it. And also such that you catch it early enough so it's maybe reversible and it's not a permanent neurological condition going forward. We want to use medications when we're prescribing for people are lowest risk for causing tardive dyskinesia. So those being clozapine, quetiapine, olanzapine are lower risk. Aripiprazole, which is Abilify, is low risk, but not necessarily the best compared to clozapine. Clozapine is the best agent, and quetiapine the best agents in folks who may have had dystonic reactions or dyskinesia in the past and need to be on an antipsychotic or a medication that you want to use to prevent it. All right, so we do focus on those medications as good options. You want to implement treatments that may reduce the presence and severity of tardive dyskinesia. Okay, if someone develops it, we do have treatments that we'll start to discuss here shortly that may be helpful in reducing or even eliminating it, and also educating doctors in training and other providers on the proper use of dopamine receptor blocking agents. Right, I see these medications overused on average for conditions that they were not meant to be used. Okay, things like someone with depression or irritability, things like that could be otherwise addressed with other interventions that are not likely to cause this condition. All right, so what you see here is actually I found this to be really helpful in my practice, a graphic from an article back in 2020 by Bashir and Yankovic, all right? And it goes through sort of the different treatments and also their level of evidence in the management of tardive dyskinesia, okay? So in the event that someone develops tardive dyskinesia, all right, one of the things that you want to do first is looking if you can do modification to their medication. Okay, can you reduce their dose? Can you maybe look at another medication that could be equally as effective and helpful to them without the risk of developing tardive dyskinesia? If finding other options, reducing the dose, making maybe making lifestyle modifications like reducing smoking, reducing alcohol use, if those things are not fully effective in reducing tardive dyskinesia, how do we do it? So if you got a patient who comes in, they've got a chronic mental illness, they have a history of schizophrenia, they've been diagnosed for 20 years, they've been on flufenazine for that entire time, and all of a sudden they're developing this tardive dyskinesia, okay? But every time you reduce a dose or you try to stop it or you switch to something else, they notice a real increase in their symptoms and they may end up getting hospitalized. Well, guess what? Maybe you can't decrease the dose, maybe you can't change the med. So what do you do? Right, that's where we start to look at these interventions, medications, natural supplements. In some cases, will involve neurology to get involved to help out with this process. Because in people who you can't stop their meds, otherwise it really does adversely impact their mental health and their personal life and their quality of life. We start to move into these new meds. Okay, and so what this table does, okay, is look at the different options. So we have things like VMAT2 inhibitors. I'll go into those in more detail. And clonazepam, which is benzodiazepine, ginkgo biloba, which is a natural supplement that we'll often see people using not only for this condition, but as an antioxidant for other conditions in mental health. It's this, and then there's also the treatment of sexual dysfunction due to antidepressants. We'll use that same medication. There's amantadine, and there's also brain stimulators that will, in very severe forms, will use botulinum toxin, which is Botox, in certain muscle groups where they're finding the tardive dyskinesia, and also alternative first and second generation antipsychotics. And then way down below, we're talking about medications that are really not shown to have much evidence to support them. As you look at this here, the level of evidence, what level A means, or sort of level, so level A largely being the amount of support and evidence that supports their use. So level A basically means there is data, there is evidence that it does improve tardive dyskinesia. Level C are medications that are possibly effective. So there may be some evidence, but it's not conclusive, right? And maybe not enough really to provide an FDA indication for these medications. Level B is, what that means is these probably are effective in treating tardive dyskinesia, but not first line and not first choice necessarily, because they are not as effective as a level A's. And level U is basically insufficient evidence to support their use in the treatment of tardive dyskinesia. Okay. All right. So the first class, okay, that we were talking about. So these are level A. These are preferred agents for someone who needs treatment for tardive dyskinesia, are vesicular monoamine 2 transport inhibitors. That is a long name, and it's reasonably complicated. So VMATs are broken down, we call them VMATs. VMATs are broken down to two forms. There's a VMAT1 and a VMAT2. So VMAT1 is found, both in the central and peripheral nervous system. VMAT2 is found only in the central nervous system, right? So basically the brain and spine. We don't want a medication that's going to affect all the other systems in your body, like your blood pressure, so your cardiovascular system, your skeletal muscle system, and things like that. We only want to target the areas that are located in your brain that cause tardive dyskinesia. So what these do is they're inhibitors. So an inhibition of a VMAT depletes dopamine and the neurotransmission of dopamine, which is believed to play a major role in the development of tardive dyskinesia, like we discussed previously. So given the current hypothesis that TD arises from upregulation of postsynaptic dopamine receptors and causes what we call dopaminergic hypersensitivity, so they're much more sensitive to, if there's dopamine present, they're more likely to receive that dopamine transmission, and because of that, cause tardive dyskinesia. These medications reduce the risk of the progression of tardive dyskinesia once it becomes present by reducing this dopaminergic transmission without further blocking dopamine receptors. Right? You have dopamine receptor blockers, but then you got these VMATs that prevent the release of dopamine into the space where it can be transferred to other cells. Now we have 3 different VMATs that are currently available to us. Okay, and they're actually available to us in the United States. They're not available necessarily all over the world. And there are only two really that are FDA approved for the use in tardive dyskinesia. So I'll go over those right now. One that's become fairly common, and you'll often find this in folks who develop tardive dyskinesia, is valbenazine. It's also known as Ingrezza. It's approved by the FDA solely for the treatment of tardive dyskinesia, with 2 supporting double-blind, placebo-controlled trials they were called the CONNECT-2 and CONNECT-3 trials, showing significant efficacy in the reduction of reducing AIM scores. So remember when I was talking about the scale that I use inpatient and outpatient to assess for tardive dyskinesia and other movement disorders, this medication, when added to their antipsychotic treatment, can reduce that AIM score for someone who's developed tardive dyskinesia. So it can reduce the severity of that condition. Okay, and that's over about a period of 6 weeks. Now, at 1 year follow-up, the data actually demonstrated showed good long-term efficacy and safety, and also tolerability in the treatment of tardive dyskinesia. So basically, after 1 year being on the medication, it was a safe drug. It continued to provide people benefit and relief. However, here's the issue. These meds are not cheap. This medication by itself for 30 days is about $7,200 a month. That's big, okay? It's still on patent. It's still branded. So this is a very expensive med. And just to get it covered, we have to do quite a bit of working with insurance companies and outside providers to get this covered. It is a very effective medication. So I find it's well worth the effort. The other medication that we've got, the other thing is, so what's nice about this, it's a medication that lasts up to 22 hours in your system, right? It's basically a once-a-day med. All right, or you can at least dose it once a day. And right now we dose it between 40 and 80 milligrams every day. The biggest side effects we find is, either largely sedation, people can develop headaches, and quite a bit of daytime fatigue. Okay, deutetrabenazine is another medication that was actually first approved for the treatment of Huntington's chorea and tardive dyskinesia. Somewhere around 2017, and actually this was following 2 very successful double-blind, multi-center randomized trials, underscoring its effectiveness and basically its effectiveness. And this is a medication because right here you can see it pretty much lasts in your body about 10 hours, right? It peaks and then starts to metabolize. So it's a twice-a-day medication. So it's not as easy necessarily to take as valbenazine, which is once a day. This you have to do around twice a day. And the recommended dosing for treating tardive dyskinesia is between 6 and 48 milligrams daily. Really, the biggest side effects with this tend to be sedation and insomnia. However, when you look at the risk of sedation and insomnia in people who take it compared to placebo, the rates are just the same. So actually, it's no worse than placebo in terms of causing side effects. Now, tetrabenazine, actually this medication, just to give you a sense of the price, is somewhere around $6,200 a month, depending on dose, between $4,200 and $6,200 monthly. Tetrabenazine is the third medication, but it does not have an FDA indication for its use in tardive dyskinesia, at least not yet. It was first developed in the 1950s as an antipsychotic, so it was meant to treat schizophrenia and schizoaffective disorder. However, over time, we've come to discover it's actually quite effective in managing things like Huntington's disease and tardive dyskinesia. It's a shorter acting medication. It lasts about 5 to 7 hours. You're going to find yourself taking it at least twice a day, if not 3 times a day. What their current recommendations are around 100 milligrams 3 times a day. That's what they were using in the studies that were showing that there was, sort of showing efficacy with the medication. Okay. Now, the medications that have I believe a level B in support, so good evidence to support it, though it's not so good that we would consider it first line, are benzodiazepines, specifically clonazepam. Now, benzodiazepines are what we know as gamma aminobutyric acid agonists. So basically GABA agonists. Okay, so they're very sedating. You can use medications like these for treatment of epilepsy or other seizure disorders. You can also use it as anxiolytics. That's where we see it most often used in mental health as an anti-anxiety drug. However, the biggest issue we have with it is addiction intolerance, right? So we do find that people can become very dependent on these medications, and it's very difficult to get them off of it. There's a lot of different benzodiazepines, right? And a lot of them are being used for tardive dyskinesia, though probably incorrectly. The only medication that we have that has some evidence to support it really is, at least sufficient evidence to support its use is clonazepam, which is a longer acting, longer onset of duration benzodiazepine. And this one has been studied in a 12-week double-blind randomized crossover trial in only 19 patients, by the way. So it's not a big study, who developed tardive dyskinesia and taking also these antipsychotics or high dopamine blocking drugs, where they were able to find that there's about 37% reduction in dyskinesia compared to baseline over that 12-week period. So they do work, but there's not a lot of evidence to support their use. In fact, the study I'm talking to you about is actually the one that I have pasted here as being one. I believe that was out of the APA, I believe it was the APA that published this a number of years back. Okay, another medication that also has some evidence of support in treating tardive dyskinesia is ginkgo biloba. Now, it's interesting because this is one of those medications that you see often. You see it like the co-op, you see it at any grocery store. You'll find it in most natural health food stores, things like that. And it's based in sort of more traditional Chinese medicine. It's one of the most widely distributed medicinal plants in the world. And oftentimes when I ask people why they take it, they don't often know why, but they find it helps. But it's largely an antioxidant, and we'll often initiate this treatment and it does show to have some effect in treating antidepressant-induced sexual dysfunction. And there is some research supporting its use, but it's also been shown to be effective in the treatment of tardive dyskinesia. In a double-blind randomized placebo-controlled study of 157 patients with both tardive dyskinesia and schizophrenia, it showed to significantly reduce those AIMS scores. So again, that scale that I will often do to measure for tardive dyskinesia and these other movement disorders by around an average about 2 points compared to placebo. Not as great. You're going to find some of the other options, things like clonazepam or even the VMAT2 inhibitors. However, there can be a benefit. And for someone who may have an addiction, but potential, or may have a history of addiction to alcohol or benzodiazepines, or maybe otherwise there's a contraindication to use something like clonazepam. This is not a bad option. It falls within the same evidence class as like clonazepam, but without all those concerns in terms of addiction and dependence. Okay, so I would not rule this out. And the dose for this would be about 240 milligrams a day for folks who develop tardive dyskinesia with their medication. Okay, I'm going to try to, I don't have too many more slides because I do want to finish up probably within the next 5 minutes to start to answer questions. So another medication that we use, and I've actually used this here at the hospital, has been amantadine, which is what we call an NMDA receptor antagonist. So what is known as to be anti-glutamatergic. So glutamate is one of the major, if not the major, excitatory neurotransmitters in the brain. So when we think about movement disorders, we think about overexcitation. Well, that's what this helps treat, is this sort of overexcitation. Right? It was initially developed as an antiviral, which was meant really to treat influenza A, however, now commonly used in treating Parkinsonism and Parkinson's and what we call levodopa-induced dyskinesia. So levodopa is a medication that increases the amount of dopamine in the brain in people with Parkinson's disease who have low levels of dopamine in the brain. And if you increase dopamine in the brain, guess what? Much like we found with the dopamine model schizophrenia, and what happens when you have long-term treatment with a dopamine receptor blocker, you end up increasing basically dopaminergic tone. So you want to sort of tone that down. This is a medication that'll help do that. It was originally studied about 1971 in people with tardive dyskinesia, and actually then later followed up with two major double-blind crossover studies showing significantly lower AIMS scores compared to placebo. Right. And it was this was more of a crossover where they did amantadine for a while, and then they crossed over to placebo and vice versa, and found that during the amantadine treatment arm, people did quite well in reducing their tardive dyskinesia. Okay. So I was quickly able to wrap up, but I want to have some opportunity to answer questions because there's a lot to do with tardive dyskinesia, because one of the issues is we don't really understand it that well, right? We only have a proposed mechanism that's not been widely understood, nor has it been really, significantly supported in the literature. We just really have a hypothesis, and based on the medications that we prescribe, and by due to the fact that we do see an improvement with these medications, it gives us some sense of what the mechanism may be, and it is largely associated with dopaminergic tone in the brain, specifically in areas related to movement and movement disorders, which is the nigrostriatal pathway in the brain, which is also related to Parkinson's disease, by the way. So that allows us some ability to get a sense of what may be happening to cause this condition. Now, this is not the only condition that arises with long-standing use of high dopamine blocking drugs. Okay, this is one of many. I think every other condition could probably be its own lecture. Things like tardive dystonia, things like Parkinsonism, things like akathisia, they all have their own, they're all these conditions that can arise from long-standing use of these meds, and many of them have different ways of treating them, right? So this is just one of these side effects from the medications over time that can develop. So there's a lot more to discuss on the matter. However, I focus just on tardive dyskinesia for the purposes of our discussion this afternoon. So, Michelle, I don't know. I can't see anyone right now, so I don't know what's happening.
So if you want to stop sharing screen, Jeff.
Yeah, I'll do that.
That was
Give me a second.
wonderful.
I'll figure out how to do it. Unshare. All right. Okay. Stop sharing.
That's it.
There we go.
Now we're good. That was wonderful. It was an immense amount of information, and really important and good information. So working at NAMI New Hampshire, I'm always thinking about the family and individual perspective, right? I'm a community educator with them. I'm also the peer services coordinator. So I think about how this impacts people who are taking these medications. I also have worked in the medical field, so I come at it from that perspective as well. And some of the statistics were just staggering, and I tried to write them down. I don't know that I got them correct, but I think you were talking with the first generation antipsychotics, that if folks have taken it for 15 years, they have like a 57% chance of developing tardive dyskinesia. So what do we say to people who are young and this medication could benefit them, yet there are these really significant side effects?
And you're right, Michelle. And actually the reason so as we're talking about pearls, right? In the first episode program, an early intervention program, there was a great chapter written by Doug Nordsey and his trainee that reviewed this a couple of years ago. We wrote a textbook together looking at these interventions. As it turns out, when you look at the medications that are currently recommended for young people with first episode psychosis, so we're talking about people maybe in their late teens, early to mid 20s, within the first like maybe 2 years of having their first psychotic episode, all those first generation agents are not listed as preferred agents, right? Yeah. So Haldol is no longer preferred agent. Fluphenazine, perfenazine, Thorazine, no longer preferred agents. What they are now is olanzapine, which is not my favorite, by the way. We can talk about that. But olanzapine, risperidone, aripiprazole, which is the partial dopamine D2 and D3 agonist, and also quetiapine, Seroquel. So of those, remember when we were going through like the low risk drugs, 3 of those are low risk drugs. Risperidone, higher risk, okay? But there are 3 out of 4 of those are low risk, right? So it gives you a sense that we do not start with those medications any longer, though, as you know, they can still develop. So the big thing, and I think this is something that you can really, you can really speak more to is that not only is it early intervention, but early education. Because I would tell you, when we have someone on the unit who needs to start these medications, it makes my job a lot easier if they know what problems can arise from it, because they know what to look for. Okay. So oftentimes I find that, either they may not remember, or they may have never been taught what these medications can do and how they can affect you, like weight gain with some of these, but also the movement disorders. Hey, by the way, if you're noticing that you're biting your tongue, or your mouth is kind of chewing on its own without you actually doing anything, or you're noticing that, your hand's kind of doing its own thing, like kind of a rolling move, that's not normal. And that's probably because of your medication. You should let someone know, because that can be treated and prevented. It's really just that simple conversation about what the side effects look like that allow you to do way less work. I work way less when someone knows what's going on, right? And so there's that. The same thing with risperidone, right? Well, what happens with risperidone? Well, guess what? Some patients will develop what we call galactorrhea. So then notice they're lactating. Why are they lactating? They're not pregnant, right? They don't have a kid. They're not they're not postnatal, but they're lactating. Why would and again, why would a 19-year-old male, natal male, be lactating? That's not a normal thing. So, and I've had people say, "Oh, it's been happening for 2 years, and I'm noticing my chest is developing, but I don't know why." Like, it's your meds. Did anyone talk to you about your medication could do that? We need to stop it. Like, oh no, I didn't know. Well, it's education, right?
And what I have seen is that folks seem to be caught between a rock and a hard place. There are patients who need medications in order to function in the world so they don't end up back in the hospital. Yet these medications have serious side effects. And I do wonder how effective we are in communicating those side effects to patients, that balancing act between this can happen, yet it's helpful for you to take it. That's a really hard position to be in.
Mm-hmm. And a lot of the medication options now, because there's like 30 different antipsychotics I have to choose from. I got a toolbox that's massive, right? So I can choose any of them. And it makes it easier too, that there's probably 3 medications that are going to be good for someone as a first drug, as a first try. And then I just kind of hand to them, like, choose one and let's talk about that one based on what you want to do. And it takes, again, it's way less work on my part because they're choosing the medication. They're going to feel more confident having chosen that medication. And then once they choose it, then I could have more of an in-depth conversation like, well, these are the problems with this one compared to the other one. Are you okay with it? Let's move forward. That kind of a thing.
And Dr. Reed, I believe that you are telling people about those potential side effects.
Oh yeah,
But
it's
I'm
like,
not sure that everyone is. I'm not sure
yeah,
that
I
all
know.
prescribers are giving people the true picture of the seriousness of the potential side effects.
Yeah, and if you look at so aripiprazole or Abilify is the most prescribed antipsychotic in primary care. Now, why is a primary care doctor prescribing Abilify? Like, I don't know. I got to tell you though that the marketing behind Abilify and the drug reps did a really good job.
Mm,
Um, but most of the patients that people are who take that medication don't have schizophrenia or bipolar disorder. So it's like, and oftentimes, like, why would a primary care doctor know the side effects? Because they're not. I mean, that's all I do. Like, I operate in a very narrow range of treating people with mental health conditions, right? So I know those things, but med students don't know those things. Primary care is not likely to know those things, and my residents barely know those things, right? That's why they're here. So it's so that's when someone comes in the hospital, sees me outpatient, like, we do a med review and say, oh, do you know what all this is? And then we do the education part, and then they're like, oh, okay, I get it now. So it is helpful. But you're right, they're not everyone knows. And not so if they don't know that, how can they educate people?
right, right. And
Yeah.
we have an ethical obligation to let people know the side effects of the medications that
Yeah.
they're taking so they can make an informed decision.
Mhm.
Yeah,
Yeah. And I try to look like very kindly upon it, because like I told you earlier, just to review tardive dyskinesia, that took 8 hours easily of just research just on this one movement disorder related to the medications. They've got all these other movement disorders, right, with other treatments. So it's very complex, and the neurobiology is very complex. So
absolutely.
I don't expect everyone to know. I just want people to be more careful when they start to select these meds, like you said.
Right. And to have patients know what to look for and family members as well.
Yeah.
I
Yeah.
know for myself, I have a family member, I have two family
Yep.
members who are taking antipsychotics, second generation, and on a different second generation med. One of my
Right.
family members started to do facial grimacing.
Yeah, that's
And
right. Yep.
right? So I have a medical background. So the minute I see that, I'm paying attention to that. Is this something with his meds? But not everybody is
Yeah.
aware. They're not sure what to look for.
Yeah. And then it gets more complicated. I mean, what's nice working with younger people too, they still have family members involved. If you meet someone in their 40s or their 50s and they've had the illness for 30 years, they may no longer have contacts with the people who may have been supporting them before. And so they're by themselves. So you're real, like, your community mental health center or your primary care are basically the people who are going to identify it, because they may actually be kind of your family, right? So not, I mean, and so it's been the benefit of like educating families at the first, early in the illness, but also like as we go forward, especially with the PEARLS program and everything, like educating like the different providers in community mental health and in primary care what this looks like, because they may not have anyone else to pick up on it.
Absolutely.
Yeah.
So you talked about people being on medications long term, and the statistics go up dramatically. I think 68% at
Yeah.
25 years is what you'd said. Do we tell people don't take these drugs? They may harm you.
I tell people they will improve your quality of life significantly. They will often help you feel safe. They will often allow you to get back to living a lifestyle that you may have once known and you may seek to get back to. However, everything that you put in your body has consequences. It's smoking, it's cannabis, it's the food that you eat, and it's the medications you take. Everything carries a risk. You have to balance that risk. What are you willing to what do you value, and what are you willing to accept as a risk? And then you make a med choice from there, right? So if someone says, yeah, you know what, I get a little bit of a tremor, I have a little bit of a sort of a grimace, but they said, I know no other medication that works to keep me safe. I need to be on Haldol. Right? Okay, so we'll start valbenazine, right, or something like that. I will start these meds in folks, right? But it's a matter of being recognizing what their risk factors are, but modifiable or non-modifiable, but also like what's the current recommendations based on the APA and what we know in the literature. And now it's, some people need to be on those first generation meds. I get it. We'll sometimes use them in the short term in a hospitalization to keep them safe here in the hospital, but not necessarily prescribe them outpatient. We'll switch them to a second generation medication prior to going, right? Or not have that as a permanent option. Start them on something second generation, but have a backup of first generation to help with agitation here and voices and seeing people, those kind of things while starting a newer med that may take a number of weeks, if not months, to really kick in. That first generation medication can be there for the short term. And if it's in there for short term, they're not on it for 5 years. They're on it for maybe 6 months.
Okay.
Right? And they're less likely to develop those side effects. So that's how I use those medications now. Yeah.
When you were talking about the medications that can treat TD, the cost of those prescription medications is outrageous.
Yeah. And they're like the standard of care, by the way, now.
Wow.
So it again underscores how important it is for you to identify early, switch to a different med if you can do it. Basically, you have to have a lot of good reason, evidence to go to an insurance company and say that they need to start a med like this. You don't just start it when you start the med. No,
Right.
that's not how it's going to work with them. They're going to ask you, did you try 5 of these other meds first before you went to this?
Yeah.
Understandably so, right? So that's why I don't often start these meds. I've never started them inpatient. I'll tell you that right now. It's something that there's a lot of other things you can do before you move to that $7,200 a month med, right? And I think that's what's important, because when we think about healthcare costs, you got to factor that in, because Medicare and Medicaid is not going to cover that without a fight,
Right.
And with good reason too, by the way. Like, we need to be diligent before we get to that.
Absolutely,
Yeah.
rather than throwing more medication on top of it. Yeah. So ginkgo biloba sounds like it's definitely a
I've
potential.
never used it with people, but it's not a bad option. I'll go with that before Klonopin any day of the week.
Yeah.
So why not?
Yeah, particularly for those with substance use.
Yeah, exactly. Or they may also be, on a stable maintenance regimen of Suboxone for managing opioid use disorder. Well, you don't want to start them on Klonopin at the same time, right? Because then that can make them, it's a dangerous combination. So then why not ginkgo biloba?
And I'm just taking a quick look in the chat and Q&A, and I think we're all set for questions. You did a fabulous job. Any last words for us?
No, I'm excited to keep, work more and more with you as I'm moving forward with the PEARLS program, or early intervention program, as we're moving towards getting that going in the next year, hopefully. And so I'm hoping to be a bit more present as my schedule gets a little bit easier and more accessible. I'm hoping to be more accessible. Maybe that's the goal for the next 12 months, more accessible. So I appreciate, and I also appreciate you reaching out and asking me to do this, because it helps me quite a bit reviewing these things, because it's been a while.
Yeah. And this is important information for individuals and families to have, and for providers to be reminded of, and for them to hone up on their education around this condition. So, Dr. Reed, we look forward to seeing you again. And just a reminder to folks, there will be a recording of today's presentation that will be posted on the onwardnh.org education page. That will be up within a couple of days. You'll also receive an email after this presentation, which includes a link to the website and a certificate of attendance for today's event. Emily, that evaluation link, if you could just pop that in the chat really quickly, so that folks can do the evaluation, so we can improve our programming. And also, I'm happy to answer any questions you have. You can reach me at mwagner@naminh.org. And we look forward to seeing you next time. Thank you very much. Take care.